Welcome to Hand Surgery Resources podcast on glomus tumors of the hand and fingers. Glomus tumors are benign papular nodular lesions that predominantly appear in the subungual region of the finger. These benign angiomatous vascular lesions were first reported by Wood in 1812, but it was the pathologist Pierre Masson who, in 1924, first made the connection between the glomus temperature regulating structures of the digits and the glomus tumor. The pathological evaluation of glomus tumors shows a proliferation of homogeneous regular glomus cells with round ovoid nuclei in a myxoid matrix with thin-walled vessels. A review of the incidence and location of glomus tumors shows that they are rare and account for less than 5% of the soft tissue tumors of the upper extremity, with 75% located in the subungual area of the digit. These lesions commonly occur in middle-aged women. The symptoms of glomus tumor include paroxysmal pain, cold sensitivity, point tenderness, ridging of the fingernail, and blue to purplish nail bed color changes in some cases. The physical examination signs of glomus tumor include cold hypersensitivity, which can be elicited by application of a cold pack, ice cube, or cold spray, pinpoint tenderness that the lesion is seen in the clinical triad, occasional ridging of the nail secondary to tumor pressure on the germinal matrix, and, finally, localized visible blue to purplish discoloration at the site of the lesion. This discoloration is caused by the hemangioma-like characteristics of some glomus tumors. After reviewing the signs and symptoms, the basis of the glomus tumor clinical triad should be easy to understand. Before modern ultrasound and MRI imaging were available, the clinical triad of pain, cold sensitivity, and point tenderness that Carroll emphasized in his 1972 paper were key to making the diagnosis of glomus tumor. At that time, only pathological evaluation of excised tissue could confirm the diagnosis. When testing for point tenderness, use an object like a pen and specifically push gently on the lesion. This maneuver should elicit exquisite discomfort. Specialized exam maneuvers have also been used to diagnose glomus tumors. Some examples include Love's pinpoint test to verify the lesion's point tenderness by using the head of a pin to apply pressure on the area of the lesion. Another example is Hildreth's test, where the temporary application of a digital tourniquet reportedly can eliminate the lesion's point tenderness. Finally, the cold sensitivity test with ice can also be useful to bring out the discomfort associated with a glomus tumor. X-rays of most glomus tumors show a normal distal phalanx X-ray. Occasionally, erosions or a dorsal concavity of the proximal distal phalanx cortex can be seen. Ultrasound is another useful tool for evaluating glomus tumors. The ultrasound of a normal fingertip shows the nail, the sterile matrix, epinicular fold, and the underlying distal phalanx. Ultrasound can localize a glomus tumor underneath the sterile matrix and germinal matrix. MRI can also be used to identify, localize, and define glomus tumors even as small as 5 millimeters. The axial view, a sagittal view, and a coronal view of the MRI all can be used to clearly delineate the location and size of a glomus tumor. MRI images can be further enhanced by using contrast. The treatment of glomus tumors is primarily surgical. The routine steps removing a glomus tumor from the subungual area are a small epinicular incision, removing the hard nail plate, opening the nail bed, and removing the glomus tumor from underneath the nail bed. To surgically excise a glomus tumor, first loosen up the epinicular fold from the hard nail plate proximally, and then either with a small elevator or with an iris scissor slide under the nail until all its attachments to the sterile and germinal matrix are loosened. Usually, the nail then simply pulls off to expose the germinal matrix and the sterile matrix. Next, the epinicular incision is made just to allow the folding back of the epinicular tissue. This allows a broader exposure to the base of the nail and the area of the germinal matrix. An incision in the matrix is made over the glomus tumor very delicately, but not into the lesion. A flap of sterile matrix and germinal matrix is carefully dissected off the distal phalanx and the underlying glomus tumor to completely expose the lesion. Next, the glomus tumor is removed from its location on the bone of the distal phalanx. After removing the lesion, the edges of the matrix are approximated and sutured with 6/0 plain catgut. When the matrix is repaired, it is important to use an absorbable stitch because the nail plate will be put back on as a temporary splint, and avoiding removal of sutures from the sterile matrix is appropriate. It takes only 2 to 3 catgut stitches to approximate these edges and keep them together while the healing takes place. 1 or 2 nylon stitches are placed in the epinicular incision. The fingernail is put back in place and held with a single suture. This suture will be easy to remove when the healing is complete. The 5/0 nylon needle through the hard nail and through the skin at the tip of the finger, so-called hyponicular area, holds the nail during early healing. This suture is just to help keep the hard nail splint positioned during the healing process. At about a week to 2, the hard nail is removed and a new nail is allowed to regenerate from the germinal matrix. The potential complications of surgical treatment are recurrence of the glomus tumor, infection, persistent pain, or recurrence of the nail deformity. Before concluding our podcast on glomus tumors, let's review some of the key points. The etiology of glomus tumors remains unknown. Clinical suspicion and an awareness of Carroll's glomus tumor clinical triad is mandatory for successfully identifying these rare tumors. Only about 1/3 of glomus tumors are associated with the blue, purplish discoloration of the fingernail. Few glomus tumors have nail deformities. Bone erosion on plain X-rays do occur, but only rarely. Further key points include special exam maneuvers like Hildreth's tourniquet test that can eliminate point tenderness temporarily in the digit, and Love's pinpoint test that can localize the tenderness to a very specific spot. Ultrasound is an excellent non-invasive tool for localizing glomus tumors. MRI can verify the presence of glomus tumors. However, false negative MRI findings do occur. Thank you for listening to the Hand Surgery Resource Podcast on glomus tumors of the finger, brought to you by the International Federation of Societies for Surgery of the Hand. For more information, sign on to our website at www.handsurgeryresource.org or www.handsurgeryresource.net. Also find our Hand Surgery Source app at the Apple Store or at Google Play. Once again, thank you for listening to our podcast on glomus tumors.